We'll try to make a quick overview on all the procedures that can be done to treat an obstruction caused by an enlarged prostate. So it's something that you already know very well, and when we have to do our job, when we have to do the surgery on our patient, because as we know, we have a lot of drugs to treat BPH, and we have a lot of sin and complication that actually lead us to say to our patient, now it's the time to go directly to the theater. And if we take a look at the guidelines that actually exactly like yesterday rely on a previous production of literature. So it's something that comes from previous 15, 20 years. This is why we still have an ancient procedure that is the TURP, the monopolar and the bipolar resection of the prostate, as one of the procedure that actually is indicated. But I saw Fernando laughing, and we laugh all the time, and anytime we are talking about the real gold standard, and we know that currently TURP is coming not to a death, but to reducing any here is rate of patient to be treated, because we know that actually we have a very short rate in which prostate are very little, so less than 30 milligrams, and you can do very little things. I mean, vaporization, you can do a TURP. When you have a prostate that is stay in between 30 and 80, you can do whatever you want. But if you are facing a prostate that is bigger than 80 grams, your choice should be the enucleation, and is what comes out from all these guidelines. You have a lot of recommendation that could be strong or weak, but the take-home message is that if you are facing a prostate that is 80 grams or bigger, you should go to the enucleation. And the only alternative to this enucleation, if you are not able to enucleate, is to do an adenomectomy. You can do it open, you can do it lap, you can do it robot, but only if you are not able to do an enucleation. I mean, with holmium, with TFL, with thulium, with green light, with bipolar energy. So there's a very wide possibility of energy to do an enucleation. In between 30 and 80, TURP still have a role, just because we have a big amount of literature, but the enucleation is also an option too. So it's finished that era in which you have the TURP till an amount and then an adenomectomy after that amount. Is starting an era, has just started an era in which the enucleation is the big rate of our patient, and then you have to manage the extremity with mist, with other kind of procedure, and maybe TURP is reducing his rate of patient. Anyone of you knows the open surgery was I think one of the procedure with whom we started as a resident. We have the transvesical adenomectomy, we have the milling that comes through the prostatic capsule, and we can do it open with our finger. And the thing that astonished me, that now we will talk about how to conserve the continence to be very tiny on the sphincter. And when we were doing the transvesical adenomectomy, actually we were not able to see where the finger was, and we have very good rate of continence, so it was really astonishing for me. Then we shift from the open surgery to the laparoscopy. That we know is for very good surgeon and it's not that comfortable if you are not comfortable with laparoscopy. And then comes out the robotics. So you can do very good adenomectomy with the Da Vinci, or with the Ugo, with the Versios, with the Inotore. We have a lot of robots on the market. And what I can say you is that sometimes it's the only indication, because if you are facing a prostate that is very big and you have, 10 stones inside the bladder, and sometimes you took more time to break all the stone instead of doing the enucleation. Sometimes it's better to remove just the stone, opening the bladder, and then doing a robot adenonectomy. So anytime you have to choose the right option in the patient. And then we have the new kids on the block. The single port is something that is really sexy from a surgical point of view, and actually is on study, so we don't have so many evidence. We already know that endoscopic surgery was born in the lower tract with monopolar and then bipolar resection of the prostate. Any one of you knows everything. So any one of you knows the red square. So all the complication we had with this procedure, the bleeding, the Tudor syndrome, all the stricture. A lot of all the stricture and all these things come from energy spreading. So it's a problem of the energy that is spreads everywhere. And then we have all the laser treatment. It's very easy to be shown. You will see in the live surgery. We just need to find out the correct plane in between the adenoma and the capsule, and then you just enucleate the adenoma. You put the adenoma inside the bladder, and then you enter with your morcerator and then remove the prostate. What is the key point? The key point is that the enucleation, like Thomas Herman loves to say, is enucleation, and something that it's similar to itself. You have to find out the capsule. It doesn't matter which kind of energy you are happy to use. Doesn't matter, HOLEP is with Holmium, so there's an interaction in between the laser and the tissue, another interaction with thulium that change if it pulsed or continuous, and change is it from the fiber or from the YAG. And then after 10 years in which all the green light laser users say that you have to vaporize, then they shift also to make an enucleation also with the green light. This is why, because enucleation is a safe procedure. It reduces the bleeding, it reduces the hospitalization, and makes patient happy. Then we have all the minimal invasive approach. We have TPLA, so we just have a needle that enter into the prostate, and with the energy makes all the cell dying because of the apoptosis. It's a very focal therapy. This is why also TPLA is also used for the focal therapy of the prostate cancer. And the big advantage is that you have 100% of ejaculation preservation, which is good for some patients. Then we have aquablation. And aquablation uses as an energy a big wave of water. And starting when it was presented 10 years ago, was a hole in the water, because they did not understand that after that you have to coagulate. Now they are restarting, and I was really impressed, because we are using it, how it works. It works very well, it is very fast, and at the end you just need to coagulate, and you have a very big hole. Sure, it's something that is PC related, and you don't have that radical adenomectomy or that radical enucleation that you can see with Fernando, But you make the patient urinate very well, and you are fast. And actually, we can start with the video. You just see in the echo animation that there's a wave that actually removes all the prostatic tissue, This is the fact that you are just adjusting what you are doing, and that wave is just removing all the prostatic tissue. And it goes very well. And you have the image just there. Resume. Instead of, it's actually using water, but it's boiling water, so it's vapor. And it's just another kind of energy, another focal therapy that brings the cells to apoptosis. So the idea is to bring all the adenomatic cells to death. Then we have very mist technique, I-tinned. It's just something that, like the champagne cable, just make a pathway in between the bladder and the urethra. And then we have the embolization of the prostatic artery, but it's something that needs a lot of study. So, which one? You have to choose, the patient has to choose, and the best way is to offer the patient everything and to choose with him the right indication for the patient. You want to ejaculate, you want not to have a problem of continence, you want to have something that is not definitive. So choose with your patient which one is the correct one. So go through a tailored therapy. We have a lot of indication and a lot of energy to do the same procedure. So talk to your patient and find out with him the right indication for his enlarged prostate. Thank you very much.
Thank you, Giorgio. I have one question, because we have a really wide number of surgeries, different surgeries, and you underline that the tailored treatment is our way. I think that we have to change also some diagnostic tools that we are using for giving this indication, because it's mandatory, in my opinion, today, especially in young patient till 65, 70, to do the endoscopy routinely before giving the indication, because in this different case you can give a different indication for bladder neck stricture, small adenoma, big adenoma, and so you can, if you have to give the indication to Eurolift, for example, or I-tinned, I think that in my opinion, endoscopy today is one of the exams that you have to do before giving the indication. What is your opinion?
Absolutely, yes. We should talk. My talk is focused once you have decided with your patient and according to your examination that the problem of your obstruction is the prostate. How many times you face a urethral stenosis starting an enucleation that you were not able to see because you didn't do any endoscopy before? A lot. This is why we need to check better our patient. So a ureteroscopy and a cystoscopy before an enucleation and before any kind of prostatic surgery is something that should be done. This avoids any misunderstood urethral stenosis, allows you to say that the prostatic obstruction that seems to be in the examination is not actually. So allows you to have a wider view and a preview of what you will be doing during your endoscopy, which is crucial. So it's something that is on the bench, it's something that we have to think about, because it doesn't make any big difference if you are facing an obstructed patient that actually has 80, 100 or 150 prostate. So we'll go to enucleate anyway. What is changing is the flow, is the residual volume, is the presence or not of urethral stricture, is the fact that is bothered or not from these symptoms, which is crucial.
As you know, it's impossible to obtain or to buy all procedures of technologies in our hospitals. In your opinion, which will be the better choice nowadays about how to treat prostate less than 80 cc's and one for bigger than 80 cc's? Which will be your better option at this time?
Okay, so first time I do agree that it's impossible for any hospital to have everything. But, well, for you and for me, yes, but not for everybody. It's, the problem is that you cannot offer everything to anyone, and it's just like we were saying yesterday about lithiasis. So we should rely on big center. There should be a big center for BPH, a big center for stenosis, a big center for lithiasis, a big center for robotics. So this is the pathway we are in Europe actually taking. For the your second question, for sure, if you are facing a prosthesis bigger than 80 grams, enucleation is the only option. Enucleation and enucleation. In between 30 and 80, there's a big gray zone, very big, like 1 and 2 centimeters in the kidney that you can do everything. And actually, you can do everything. The best procedure you can do is the choice for the patient. So if you have a very good 2RP receptors, maybe this is the good option for you and your patient. If you do very good enucleation is the one you have to do. If you have a very big experience on aquablation, maybe that one is the correct one.